Welcome to Cardiology Section 4. Follow with us as we review valve disorders.
I'm going to talk about aortic stenosis, pulmonary stenosis, all of these systolic and diastolic murmurs. I'll discuss Mr. Taps with you. These are the heart sounds in a graphic representation, so you can see that the PDA is throughout systole and diastole. You can see when the different murmurs occur and kind of where they get the crescendo, decrescendo terms from. It goes up and then goes down, or it happens throughout the entire phase of the cycle. Now with murmurs, they can be classified in several different ways. If you're a PANCE, it's likely they're going to ask you, if you know these 7 characteristics, they'll give you several of them and ask you which one's missing. Timing, shape, location, radiation, intensity, pitch, and quality. These are what they're going to talk about. The important thing is also where the locations are, where you're going to listen to different spots of the heart. And then here for both PANCE and PANRAIS, they're going to talk about here a murmur. And they're 1 through 6, so there's 6 levels to the sound of a murmur. But it's important to know that from 4, 5, and 6, you'll have a palpable thrill. In other words, if you're listening to the heart and you hear the murmur and you were to put your hand there, you would actually feel like a thrill of fluid flowing underneath your hand. That's what defines a 3 from a 4. So these two will sound about the same. The difference is this has no thrill, a 4 has a thrill. So 3 or less, no thrill. 4 or higher, there's an actual palpable thrill. So that's important to know when they're describing the murmur to you. If it's written in there, you feel a palpable thrill, you know it has to be at least a 4, 5, or a 6. All right, so we're going to do Mr. Taps. Mr. Taps is pretty much something that we came up with to help you remember all your systolic and diastolic murmurs quickly and easy, just remembering these 6 letters right here. I think of Mr. Taps as being the heart, and it makes, your tapping noise all the time, so that's how I think of the cardiac heart murmurs. It's easy to make all the ones you need. So what we're going to do is these are the systolic murmurs, and you're just going to write it sideways like this. You're going to go MRT and APS and put a line right there. What this is going to do is going to help us figure out the murmurs. So the first thing you need to know is we always read normally from left to right here, so MRT, APS. So since we've turned it sideways, this is our starting point to read. Because of this, when we read this direction, it's easy to remember that all systolic murmurs are going to radiate up. So they're all going to radiate this way. So aortic stenosis radiates up. Any of the systolic murmurs you find will radiate upwards. So what murmurs can we make? That's the real question. So we got these 3 letters here and 3 letters here. So what we can do is there's MRT and then there's APS. So here I can make the murmurs TR and MR. Mitral regurg, tricuspid regurg. You only have 2 choices. It's either stenosis or regurgitation. So up here, since we got the S, it must be AS and PS. So here we get aortic stenosis and pulmonic stenosis. So these are the 4 systolic murmurs that you're going to get, AS, PS, TR, and MR. Then sometimes they're going to ask you, where are the components of the heart? They're going to ask you where you use the bell and the diaphragm. They're also going to ask you where the apex or the base of the heart is. So using the same thing as always reading from here to here, we can note that, and this just here defines what ASPS is, aortic stenosis, pulmonic stenosis. So the S1 and the S2, they often ask you where is it the loudest, where do you hear it? And it's easy to do this because we know that number 1 comes before number 2. Since we started from here to read, S1 is down here, S2 is going to be up here. And then they'll ask you, what are the components of S1? And sometimes you're stressed and you can't remember. Well, if you've already written this out, it's the tricuspid and the mitral valve closing together that make up the S1 heart sound. And it's the aortic and the pulmonic valves closing together that make the S2 heart sound. So what this means is if I was to listen up here, which is at the base of the heart, S2 would be the loudest, and down here, S1 would be the loudest. So how do I remember where the apex and the base is? I do the same thing. Sometimes people think of apex as being the top, and you get confused. You can't remember during the test. You're stressed. It's easy. A comes before B. 1 comes before 2. We know we always read this direction. So all systolic murmurs radiate up. I take these letters and I can make these murmurs. S2 is up top here because 1 comes before 2, and we know this is the apex of the heart and that's the base of the heart. So now you ask, how do you use the bell and the diaphragm? Well, sticking with our alphabet and number system, we know that we're going to use the bell B and the diaphragm up here. So the bell is best used to hear these heart murmurs, and the diaphragm is best used to hear these up here. So you can just use Mr. Taps to easily figure out these heart murmurs, where you hear S2, where is S1 the loudest, which is the apex, which is the base, where you should use your stethoscope. Now you can take this and you can just invert it and you can make this your diastolic murmurs. So if all systolic murmurs radiate up, that means that all diastolic murmurs will radiate down. Then you just have to take the opposite of what you had here. If it was stenotic here, it means it's regurg. If it's regurg here, it means it has to be stenosis. So if it was AS, it becomes AR. If it's PS, it becomes PR. If it's TR, it has to be TS, and MR becomes MS. So these are your diastolic murmurs. They all radiate down. So now you have 8 murmurs really fast. You can do it in your brain. So somebody tells you it's a systolic ejection murmur. Well, as soon as you hear the word systolic, you know it has to be one of these 4, and you can just go Mr. Taps. In your brain, you can go MR, TR, AS, and PS, or you can just write it on your little whiteboard and write this out really fast, and you're going to get 2 or 3 questions right nice and easily. Just by using these 6 letters right here, it gives you a nice pattern to open up this whole entire flow right here. 6 little letters, and we get all this information. So, aortic stenosis. This one here is murmur that happens at 2 phases in life. It's either the younger adult or the older adult. If it happens before the age of 50, it's because the patient had a bicuspid aortic valve. If it happens around the age of 75, 80, then it's likely just valve calcification and scarring. So either one of them, the classic symptoms that you're going to read in the question are ASH, angina, syncope, and heart failure, ASH. That's the mnemonic you remember with aortic stenosis. And the symptoms they're going to present with are angina, syncope with effort, and heart failure. These are the 3 symptoms they get when they have this aortic stenosis. So the physical signs you see with aortic stenosis, they get this narrow pulse pressure. They have an apical lift. An apical lift, what that means is if you were to put your hand on the left chest, your hand would actually raise up. An apical lift in your brain should mean that they have a hypertrophic heart. It's a big muscle there because it's trying to push open this blood through this very narrow valve. So an apical lift means hypertrophic cardiomyopathy, it means LVH, it means somebody who has hypertension. So aortic stenosis, the left ventricle had to compensate, get bigger, so that's why you get this apical lift. They also get this ejection murmur and they'll have an S4 gallop. Remember, if they have the apical lift, that means they have LVH. LVH means a stiff ventricle, and that means you'll have the S4 heart sound. And they'll have this slow carotid upstroke. The classic symptoms, ASH, angina, syncope, and heart failure. These heart symptoms are the same ones that you'll see in hypertrophic cardiomyopathy or younger men. Typically it's boys with hypertrophic obstructive cardiomyopathy or just hypertrophic cardiomyopathy. So they are young kids who get these big, thick ventricles. And they have the symptoms are exactly the same. They'll get angina or chest pain, they'll pass out, and they end up with heart failure. So the physical exam, we described all of these things here. Remember there's LVH, so that's why you get the S4 heart sound. So with these patients here, you got to be cautious when using nitrates and ACE inhibitors because that can cause them to get very low blood pressures. The treatment is to do valve replacement. So remember, if they're young, by the age of 50, then they had a bicuspid aortic valve. Bicuspid aortic valves lead to early aortic stenosis. So sometimes they'll ask a question, young man comes in, he's got coarctation of the aorta, he's got associated bicuspid aortic valve. What counseling will you have to give to the parents? And you have to give counseling to the parents that he's going to require aortic valve surgery because he's going to get aortic stenosis early or by the age of 45, 50. There's also Gallivardin's phenomenon, which is the murmur that you have associated with aortic stenosis. It's this musical sound that you hear in the ventricle. And remember that aortic stenosis radiates to the carotids. The murmur radiates up into the carotids. Aortic regurgitation, there's 2 things that can cause it. It's either the leaflets themselves get degenerated and they can't close to keep the door completely closed. They don't either fit anymore or they're too floppy to close and blood can pass past them. Or the aortic root just dilates. The circle ring that holds the leaflets in place, it dilates and so the leaflets just can't cover the space. So aortic root enlargement, hypertension is the most common cause of aortic regurgitation. People with Marfan, syphilis, and any kind of connective tissue disease also end up with aortic root regurgitation. This is why you hear of aortic dissection in patients who have Marfans. And then the leaflet degeneration, rheumatic fever, endocarditis, connective tissue disorders. These are all the leaflets either too weak or the endocarditis, the bacteria chews the leaflets up. So they can get either acute aortic regurgitation or chronic Acute aortic regurgitation, they're not going to ask you a question about this, because if you go into acute aortic regurgitation, then that means that something happened urgently. You're going to go into systolic heart failure rapidly. You're going to need to be intubated or you're going to die. So they're really not going to ask that question unless they're asking you what are the consequences of aortic root enlargement, something like that. But it's probably going to be chronic aortic regurgitation. They're going to ask you about this patient here and how you're going to treat it. So patients are typically asymptomatic with chronic aortic regurgitation because the leaky valve is not too bad initially. But over time, it causes left heart failure. They get fatigue and dyspnea, palpitations, angina, and aortic regurgitation has an Austin Flint murmur associated with it. So aortic regurgitation is treated just like systolic heart failure. And as we go through this cardiology section and we get to the cardiomyopathies, I have a very large slide that kind of summarizes all of the heart murmurs and the cardiomyopathies into one easy to look at slide and help you remember things. So the mainstay of treatment for aortic regurgitation is in the early stages, ACE inhibitors, diuretics, and beta blockers, and then surgery to repair the valve is a definitive treatment. So if they only choose medications, it's always an ACE inhibitor, loop diuretic, and beta blocker. These are the same agents that you use for systolic heart failure. And they're the mainstays of treatment. Otherwise, do valve surgery. The interesting thing about aortic regurgitation is that about 16,000, it seems, named findings as Quickney's, Corrigan's, DeMusset's, Traub's, Mueller's sign. And what we're saying is here, Mueller's sign is if you look in the mouth of somebody who has aortic regurgitation, you'll see the pulsation of the uvula. Or take DeMusset's sign. The head will actually bob in time with the heart murmur, which is actually diastolic. But you'll have systolic head bobbing as the blood's coming out. Their head will bob and then go back down as the blood goes back into the left ventricle. So these are all different signs. So how do you remember all of these? I don't. What you do is you remember the few that are out there, and then everything else has to be aortic regurgitation. And I'll show you what I mean by that at the end. Mitral stenosis, rheumatic valve disease is the #1 cause of this. As soon as somebody has mitral stenosis, they developed pulmonary hypertension. It's not a secondary cause. It's actually what happens as soon as you get mitral stenosis. Because the mitral valve gets very stenotic, the left atrium here gets full of blood and has a hard time pushing it through. This causes the backup into the lungs, and so the lungs, their goal in life is to push blood forward, so they get hypertrophic to keep blood moving forward, helping the left atrium push blood through the stenotic valve. So as soon as you get mitral stenosis, you start getting pulmonary hypertension. People who have mitral stenosis have a high incidence of atrial fibrillation. What you need to know is that any structural change of the atrium, whether you make it dilated or it becomes hypertrophic, bigger, means atrial fibrillation is the rhythm that you're likely to get. The same holds for the ventricle. Any dilated ventricle or any hypertrophic ventricle means that they're going to get ventricular tachycardia. So there's a rhythm associated with the ventricle and a rhythm associated with the atrium. You can get other rhythms, yes, but what I'm saying is if you have a structural change in the atrium, the most likely rhythm is AFib. You get a structural change in the ventricle, the most likely rhythm is ventricular tachycardia. So if you get a dilated heart, VT is a risk. Get a low ejection fraction of 20%, dilated cardiomyopathy, ventricular tachycardia is why we use an AICD in those patients. Somebody has mitral stenosis. This is kind of caused the left atrium to become hypertrophic. It's kind of trying to get stronger so it can push the blood through that tight, narrow valve. Anytime a structural change of the atrium happens, it means atrial fibrillation is the risk that they're going to get. So the symptoms they get is PHD for mitral stenosis, and PHD stands for palpitations. This is the AFib, heart failure, and they get dyspnea on exertion. What we're talking about here is that systole and diastole at rest they're about the same. The diastole is longer than systole, and then as you start exercising, they become about the same amount of time in the cardiac cycle. So at rest, diastole lasts longer than systole, so these people aren't short of breath. But then as you have them start to exert themselves, running, the heart rate goes faster, diastole and systole occur with about the same amount of time. And because of this, they don't have as much time to fill a ventricle, and they get short of breath when they exert themselves. There's a lot of signs with mitral stenosis. There's Ortner syndrome. This is a hoarseness in the voice. It's because the left atrium becomes enlarged and it pushes against the left recurrent laryngeal nerve, and that's what leads to the hoarseness. They get mitral phases. They get this pink, purplish patches on their cheeks due to low cardiac output. They may or may not have P mitral on the EKG, where they have that really tall P wave. Pregnancy is usually the first time that we find out somebody has mitral stenosis. In other words, they're doing fine, life is good, they get pregnant, and they have that extra fluid running through the system and the extra weight with the baby, and that's what all that extra fluid trying to move from the lungs down, you'll find out that they have mitral stenosis. It sounds like a murmur of mitral stenosis is an opening snap. It's a decrescendo, low-pitched diastolic rumble, best heard at the apex of the heart. The treatment is definitive, is surgery. Medical treatment, if you have used only medicines, is use a beta blocker or a calcium channel blocker, anything that will slow the heart rate down, allowing the longer diastole, actually not longer systole, but diastole. So you want diastole to be longer so you can fill more, get more blood, push it out to the body. So increase the heart rate, they get more shorter breath. Slow the heart rate down, they're less shorter breath. And if they ask the question, how do you take care of somebody with mitral stenosis when they're pregnant? You can actually just do a balloon valvuloplasty to get them through the pregnancy, and then you can do the surgery afterwards. Mitral regurgitation has the same symptoms, palpitations, heart failure, and dyspnea like mitral stenosis does. The difference is it's a holosystolic, high-pitched murmur, best heard at the apex. And you hear it best when they're in the left lateral decubitus position. This murmur here actually radiates up to the axilla, where aortic stenosis radiates up to the carotids. Remember, because mitral regurgitation causes the atrium to dilate or the wall to thin out because of all the extra blood getting shoved up in there, it's a structural change, which is why they get the AFib. The treatment for mitral regurgitation is surgery, and the treatment is just like systolic heart failure. So you treat the mitral regurgitation just like you treat the aortic regurgitation. They both look like systolic heart failure. The causes of MR, commonly, remember that they have the chordate tendinae, so after a heart attack you can rupture the chordate tendinae and that causes the leaflet to be floppy. Valve degeneration from endocarditis, or the root can dilate itself as well. Mitral valve prolapse. This is generally a young lady. Doesn't have to be, it happens in men as well, but generally it's a young lady. She complains of stress, anxiety. She's going to be complaining of a sharp, jabbing chest pain. It's not anginal. She'll be complaining of palpitations, but if you put a monitor on her, she won't have any EKG changes. You won't detect any arrhythmias, and she'll be complaining of shortness of breath. It looks like a lot like anxiety with some chest pain. On examination, however, you'll find a mid-systolic click and a late apical systolic murmur. The mid-systolic click is important. This is kind of pathognomonic for the mitral valve prolapse. What's happening is the left ventricle is building up pressure to open the aortic valve. The mitral valve is closed, and what happens is as the pressure builds up, it actually pushes the mitral valve upward, and the leaflets, these people have these floppy leaflets, and so as it pushes upward, the leaflet will actually pop through because of all the pressure, and that will cause the snap or that mid-systolic click, and that's when they get that little bit of a systolic murmur. The main treatment for mitral valve prolapse is just reassurance, and if they need a medication, beta blockers are used. Over time, mitral valve prolapse leads to mitral regurgitation, and then you just treat it like mitral regurgitation. Tricuspid stenosis. The most common etiology of this is actually rheumatic fever. So if you have tricuspid stenosis, then you probably have mitral stenosis. It's a mid-diastolic murmur, best heard over the left sternal border with a rumbling. Patients who have tricuspid stenosis look like they have right heart failure. They have this jugular venous distension because the blood's having a hard time getting from the right atrium into the right ventricle. The treatment is just surgery. Just noting, rheumatic fever. If it affects the tricuspid valve, then it also affected the aortic and the mitral valve. If rheumatic fever just affects the mitral valve, that's possible. If rheumatic fever affected the aortic valve, then it probably affected the mitral valve. So the order is, rheumatic fever affects the mitral first, then the aortic, then tricuspid most commonly. So if somebody has tricuspid stenosis due to rheumatic fever, they probably have some aortic stenosis and mitral stenosis due to the rheumatic fever as well. Tricuspid regurgitation. Epstein anomaly is the most common cause of this. What happens is the valve just sits too low, causes the chordae to be too floppy, and so the leaflets don't close properly. In adults, it's commonly due to endocarditis. Lupus can do it. But also there was that fen-phen, this diet drug that was causing cardiac problems, and this is what was causing tricuspid regurgitation, was that fen-phen. So you get this pansystolic murmur. It's called carvalocide. It's another one of the signs you get to memorize. And the signs of somebody who has tricuspid regurgitation, again, it looks like right heart failure. They get a jugular venous distension and all the blood backs up to the JVD, to the liver, and then to the legs. So diagnosis is just by echo, and we do surgery on this if it's causing symptoms, but it's rare. They usually have to have tricuspid regurg plus some other valve before they'll do surgery. If they do have tricuspid regurgitation, I forgot to say this part, is do remember that IV drug users, when they put the IV needle in, it goes to the venous system. Remember, it's going to be Staph aureus, and the first valve that it'll encounter as it's on its way back to the heart is actually the tricuspid valve. So a young guy with suspected IV drug use, new tricuspid regurgitation, think endocarditis. Pulmonary regurgitation. Pulmonary hypertension is the most common cause of the pulmonary regurgitation. You get shortness of breath on exertion is their most common complaint, and it's associated with any of these things here that cause pulmonary hypertension. So scleroderma, any shunts, tumors, all the classes 1 through 5 that lead to pulmonary hypertension cause pulmonary regurgitation most commonly. It's rarely a problem though, and we rarely try to repair a pulmonic valve that's regurgitating. Just try and correct and control this underlying cause. It does have a murmur associated with though. It's called the Graham-Steele murmur. So it's something that you need to know. And these are just the groups of pulmonary hypertension I was talking about. All these different groups here can lead to pulmonary hypertension. We did this in the pulmonary section. Pulmonic stenosis. This is commonly seen in kids who have Noonan syndrome. And Noonan syndrome, it looks a lot like Turner syndrome. They'll have pulmonary stenosis and ASD, hypertrophic cardiomyopathy, and a short stature, and these other findings. Carcinoid syndrome happens in adults to cause pulmonary stenosis. I don't see them really asking too much of this kind of question unless they're asking associated with these childhood conditions. But it looks like right heart failure. And then valve replacement. We talked about doing valve replacement. Mechanical valves, the important thing about them is that they are metal, so they require anticoagulation to prevent them from breaking down the red blood cells and forming clots. So when you do an examination on somebody who has a mechanical valve, you should hear a click. If you don't hear a click, that's bad, and they need to be anticoagulated. The goal is 2.5 to 3.5 when using the Coumadin. That's the INR goal. And somebody who has atrial fibrillation, our goal is 2 to 3, or anybody that needs anticoagulation, typically the goal is 2 to 3, but with valves it's 2.5 to 3.5. Anybody with a biological valve, you don't need the anticoagulation, and the examination should be normal. There will not be a click. We also have closure devices to use like for an ASD or a VSD. So remember that mechanical valves have a click. You hear the metal clinking, and the INR is 2.5 to 3.5.